All right. Good morning, everyone. Welcome to DUR Medicaid May DUR. Thank you for your attending to our DUR board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and to mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board member, please preserve the question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide a public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meetings to help us improve our process moving forward. Thank you. And Dr. Eric Cannon's unable to join us this morning, so I will be running the meeting this morning. The first item on the agenda is review and approve of the minute. Do I have a motion to approve the minute? The April meeting minutes?
Motion to approve.
Thank you, Dr. Hancock. I have a second.
I'll second.
Thank you, Dr. Siegfried. All approve? All in favor?
Aye.
Aye. Any opposed? Motion passed for the minute. The next item on the agenda is the new updated DUR bylaw. So in the reminder email, I have sent all the board members the updated DUR bylaw. First reason that we want to update the bylaw is because of the merger that happened with the Utah Department of Health and Integrated that happened in July of 2022. So we are updated the bylaw for the new logos. Also take an opportunity to update some of the language. With that, I hope everyone had the time to review the bylaw. Did a motion to approve the bylaw? Any discussions?
Motion to approve.
Thank you, Dr. Smith. Do we have a second?
Second.
Thank you, Dr. Hancock. All in favor?
Aye.
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 Any opposed? Motion passed to approve the bylaw. Thank you very much. The next item is the P&T update. Brian, do you want to give an update?
Yep. So last month we reviewed anti-VEGF IV, or not last month, in February. Next week we will be reviewing the last of our anti-VEGF series, the oral, and we will also be updating our bylaws for P&T committee. And as P&T committee is a subcommittee of the DUR board, after those minutes have been reviewed by the P&T committee, we'll bring those to DUR for final ratification.
Thank you, Brian. Next item on the agenda is the presentation for Singular or Montelukast from the University of Utah.
All right. Good morning, everyone. Hopefully you can see those slides. Today, I will be reviewing Montelukast or Singular, focusing on its approved indications, the rationale for its black box warning for serious neuropsychiatric events, and Montelukast utilization data among the Utah Medicaid fee-for-service population. Montelukast has been approved by the United States Food and Drug Administration, or FDA, since 1998. It is indicated for the treatment of asthma in patients aged greater than or equal to 1 year, seasonal and perennial allergic rhinitis in patients as young as 2 years or 6 months of age, respectively, with an with an inadequate response or intolerance to other treatments, and for prevention of exercise-induced bronchoconstriction or EIB in patients aged greater than or equal to 6 years. Montelukast is a leukotriene receptor antagonist available in various oral formulations with the recommended dosage based on age. Montelukast is taken daily for asthma and allergic rhinitis or as needed at least 2 hours before exercise for EIB prevention. For more than a decade, the FDA has continually received post-marketing case reports of potential neuropsychiatric events in adults, adolescents, and children exposed to Montelukast. Prior to implementing the more recent black box warning for neuropsychiatric events, the product labeling for Montelukast has undergone several revisions. While these revisions were aimed at disseminating the potential risk of neuropsychiatric events to patients and providers, there remained concern for the lack of awareness, particularly in pediatric patients. In response, in 2019, the FDA reevaluated data from the FDA Adverse Event Reporting System, or FAERS, and published observational studies for neuropsychiatric events. Additionally, the FDA conducted an observational study using claims data from 2000 to 2015 from the Sentinel Distributed Database. The next couple of slides will highlight the findings from each of these endeavors. Of the 19,685 FAERS case reports of any adverse effect in patients taking Montelukast over 21 years of prescribing in the U.S., 52% had a keyword of interest related to a potential neuropsychiatric event. Of these, approximately 84% of cases were serious. Overall reported neuropsychiatric events in Montelukast-exposed patients were highly variable and ranged widely in severity. Temporal trends from Montelukast case reports revealed increased reporting of neuropsychiatric events in 1999, 2008, 2013, and 2018, but this was likely attributable to heightened public awareness as a result of FDA safety communications and increases in duplicate or foreign reports. Over the 21 years of Montelukast FAERS case reports, there were 82 cases of completed suicide, many of which documented the onset of neuropsychiatric symptoms before the event. Of these, about 55% involved patients 17 years of age or older, and approximately 23% occurred in those 17 years of age or younger. Most of these reported cases lacked adequate information for assessing the association between Montelukast and the suicidal event, but among the reports with more comprehensive details, it was noted that other potentially contributing risk factors for suicide were present. While most events were reported during Montelukast use, there were 2 cases in which events occurred after Montelukast was discontinued, and overall conclusions regarding causality were limited by the lack of reported information. As part of a safety review specifically in pediatric patients in 2019, the FDA evaluated 4 published observational studies regarding pediatric Montelukast use and neuropsychiatric events, 1 cohort study, and 3 nested case control studies in children with asthma. The FDA focused primarily on pediatric patients, possibly because the neuropsychiatric safety concern was brought to the FDA Pediatric Advisory Council in response to citizen petitions from parent advocacy groups. For the sake of time, I will provide a brief overview of the results. Please refer to Table 1 and our pages 6 to 8 of the report for additional details. Results from these 4 observational studies were mixed regarding whether Montelukast was associated with neuropsychiatric events. Schumacher et al. And Ali et al., which were studies judged to be of higher quality by the FDA, did not find a statistically significant association, while the study by Bernard et al. Found a 9 to 12-fold increased risk of neuropsychiatric events resulting in drug discontinuation associated with Montelukast, with or without an inhaled corticosteroid or ICS. Compared to ICS alone, the extremely large confidence intervals for the findings of this study indicate poor reliability in the results. Overall, the FDA decided that the reviewed observational studies did not provide definitive evidence linking Montelukast use to the development of neuropsychiatric events in pediatric patients. These observational studies had important limitations, such as unadjusted confounding factors related to pre-existing psychiatric conditions or concomitant medications with possible neuropsychiatric effects, which motivated the FDA to conduct its own observational study. The objective of the FDA's observational analysis was to address whether montelukast use for asthma was associated with an increased risk of self-harm, suicide, or depressive disorders relative to ICS treatment, and whether results were influenced by the first FDA warning announcement in 2008 about montelukast and the potential for neuropsychiatric events, or subsequent montelukast labeling changes. The study included patients with asthma without chronic obstructive pulmonary disease who were at least 6 years of age. Patients with allergic rhinitis were also included, but only if asthma was the primary diagnosis. The study included patients who were recent initiators of therapy, or in other words, patients without recent exposure to montelukast or any ICS-containing therapy within the previous 183 days of medication initiation. Patients who received either montelukast or ICS monotherapy during the observation period were matched in a 1-to-1 ratio using propensity scores. After propensity score matching, 457,377 patients were included in each exposure group. The matched cohort was primarily female with a mean age of 38.5 years. Approximately 37% of patients had a history of a psychiatric disorder, and 43% had a concurrent diagnosis of allergic rhinitis. Additionally, about 63% and 20% of patients had a history of using short-acting beta agonists or SABAs and or oral corticosteroids, respectively. Compared to ICS monotherapy, montelukast monotherapy was associated with a significantly reduced risk for outpatient treatment of depressive disorder, even among pediatric patients 12 to 17 years of age. But authors of this observational analysis mention this finding should be interpreted cautiously. Additionally, there were no significantly increased risk of inpatient-treated depressive disorder or self-harm associated with montelukast monotherapy compared to ICS monotherapy. Even though the risk of neuropsychiatric events with montelukast remained elusive, with building evidence showing no risk, in 2020, the FDA made 2 changes to the montelukast labeling to increase patient and provider awareness about the possibility and potential seriousness of neuropsychiatric events, but also with the objective of maintaining access to montelukast for patients who benefit from this therapy. The first change was to elevate the level of warning for neuropsychiatric events to a black box warning, and the second change was to recommend against montelukast as a first-line treatment for allergic rhinitis and reserve the allergic rhinitis indication for patients with an inadequate response to other treatments. The FDA concluded that the potential neuropsychiatric risk outweighed the potential benefit of montelukast as first-line treatment for allergic rhinitis, because allergic rhinitis is usually a mild disease and is treatable with other safe and effective options. No changes were made to the asthma and EIB indications, with appropriate montelukast use for these conditions to be determined by provider discretion on an individual basis. Regardless of age, the current montelukast labeling advises that providers inform patients of the potential for neuropsychiatric events and that patients and caregivers should monitor for behavioral changes and new neuropsychiatric symptoms and discontinue treatment if they occur. To complement the observational evidence reviewed by the FDA, we identified more recent systematic reviews. The systematic review by Lowe et al. Included various study types in adults and children with asthma, whereas the systematic review by Mao et al. Included a meta-analysis of randomized controlled trials, or RCTs, only in adults and children with asthma and/or allergic rhinitis. In total, 59 studies were included by Lowe et al. With comparisons between montelukast and non-montelukast users, and 18 RCTs were included by Mao et al. With comparisons between montelukast and placebo or active comparator. 6 RCTs compared montelukast as adjunctive therapy to loratadine or budesonide versus loratadine or budesonide monotherapy, respectively. The systematic review by Lowe et al. Found that montelukast exposure was not associated with a significant increased risk of suicide-related events and mixed results for an association to depression. In some, but not all studies, montelukast use in adults, especially older adults, was associated with an increased risk of anxiety, other anxiety-related disorders, and sleep disturbances or disorders. Overall, conflicting results were found for an association between montelukast use and the risk of neuropsychiatric events in observational studies exclusively of pediatric patients. The meta-analysis of RCTs found no significant association between montelukast exposure and the risk of neuropsychiatric events compared to placebo in patients with asthma and/or allergic rhinitis, including among pediatric patients less than or equal to 14 years of age. Additionally, montelukast was not associated with a significantly increased risk of neuropsychiatric events when added to budesonide or loratadine compared to budesonide or loratadine alone, respectively. The quality of observational studies included by Lowe et al. Varied from poor to high. Most RCTs included by Mao et al. Had a low risk of bias. Reviewed guidelines tend to recommend montelukast as a second-line or alternative option as monotherapy and/or an option for add-on therapy to first-line treatment, generally due to the potential risk of neuropsychiatric events and/or inferior efficacy to first-line options. For the treatment of asthma in pediatric and adult patients, leukotriene receptor antagonists, or LTRAs, are an alternative option as maintenance monotherapy for mild persistent asthma and one of several alternative options for add-on therapy to an ICS-based maintenance regimen for moderate to severe asthma. For EIB prevention, montelukast is typically an alternative option or an add-on option to first-line therapy, which is generally a SABA. Because tolerance may potentially develop with frequent or prolonged beta-2 agonist use, LTRAs may be beneficial for patients with EIB who exercise frequently to supplement SABA treatment. In agreement with the FDA's guidance and montelukast labeling changes for allergic rhinitis, the reviewed allergic rhinitis guideline conditionally recommended against LTRAs as initial first-line treatment for intermittent or persistent allergic rhinitis in patients 12 years of age or older, which was the only age group addressed by this guideline. This slide shows the off-label uses for montelukast in pediatric and adult patients as indexed in the drug compendium Micromedics and LexiDrug. Examples of recognized off-label uses include urticaria, atopic dermatitis, allergic conjunctivitis, and obstructive sleep apnea. As indicated by pharmacy claims over the past one-year period from March 2023 through February 2024, in the fee-for-service Utah Medicaid population, the age group with the greatest proportion of patients receiving montelukast of any formulation was adults, followed by similar proportions in children less than or equal to 5 years of age and 6 to 10 years of age. Most patients filling montelukast across all age ranges had at least one ICD-10 diagnosis code related to an approved use of montelukast. While a considerable amount of patients lacked an ICD-10 code specific to asthma or allergic rhinitis, it is possible some patients had an indicated use, but it was not represented in their ICD-10 claims record in the past year of observation or was reflected by less specific coding. We looked further into patients in these two highlighted cells that did not have an asthma or allergic rhinitis diagnosis code within the last year to see what other codes they had that might be related to montelukast use. This slide shows ICD-10 codes potentially related to an on-label or off-label use of montelukast in the subset of pediatric patients 14 years of age and younger without a specific ICD-10 code for asthma or allergic rhinitis. Although we cannot interpret that patients were certainly using montelukast to treat these conditions without further investigating on an individual level, it provides an idea of potential indications for which these patients might be using montelukast. Please refer to Table 11 of the report for additional ICD-10 codes not listed on this slide. According to the FDA, the black box warning for montelukast is intended to increase patient and provider awareness about the potential risk of neuropsychiatric events with montelukast and to help ensure that the use of montelukast is limited to patients in which the anticipated benefits outweigh the potential risks. Considering that the association between montelukast and risk of neuropsychiatric events has been inconsistently demonstrated with evidence showing neutral or reduced risk, along with the FDA's intention to maintain patient access to montelukast, we suggest prioritizing educational outreach or retrospective DUR interventions rather than more restrictive approaches. If implementing one of these interventions, healthcare providers could be advised to counsel all patients and/or caregivers about the potential risk of neuropsychiatric events when prescribing montelukast, and to monitor all treated patients for such events during montelukast use and after discontinuation. Patients should be counseled to stop montelukast immediately if any neuropsychiatric symptoms or behavioral changes occur. Providers, as well as patients and/or caregivers, should be encouraged to voluntarily report any adverse effects related to montelukast to the FDA MedWatch program. Alternatively, if desired, a prior authorization for montelukast could be implemented to ensure that montelukast is prescribed for conditions where the potential benefits outweigh potential risks. A caveat is that the prior authorization workload to meet patient needs for montelukast may be overwhelming for prescriber offices, given that montelukast is currently utilized by over 2,000 patients in the Medicaid fee-for-service population. Potential prior authorization criteria may include ensuring montelukast is prescribed in accordance with FDA labeling, and that the individual benefits and risks are evaluated by the provider before prescribing or continuing montelukast. As a reminder, for the treatment of allergic rhinitis, montelukast should be reserved for patients with an inadequate response or intolerance to alternative therapies. Off-label use of montelukast should be considered cautiously and only for indications in which there is sufficient evidence of benefit and/or insufficient alternatives with a superior efficacy and/or safety profile. You may consider requiring providers, excuse me, you may consider requiring providers acknowledge that they counseled patients who are taking montelukast about potential neuropsychiatric risks, and that the patient and provider will monitor for such or development of such events. This concludes the presentation. Thank you for your time and attention, and please let me know if you have any questions.
Thank you, Monette. Do you have any questions for Dr. Lulo from the board? All right. Thank you very much. We're going to move on to the next. Is the proposal from the Utah State. So with the presentation from the DRC, we take a look at our policies and several other state policy as well, ACO. So we come up with at least put in an A limit to montelukast. We recommended to put an A limit of 12 years old and up for oral 4 milligram granules package of montelukast. For the chewable 4 milligram 2 years old and up, and chewable 5 milligram is 6 years old and up, and then for tablet 10 milligram is only limited to 15 years old and up. These A limit proposal is aligning with the FDA package for these products. When looking at other state and ACO, we found that Vermont also have an A limit for montelukast. They limit to 4 milligram chewable from only 2 to 5 years old and 5 milligram for 6 to 14. And I assume in 10 milligram for 15 years old and up as well. Our ACO, like Select Health, Molina, Healthy U, and Health Choice, they all have quantity limit apply, 30 tablets for 30 days for the montelukast and brand Singular. Does the board have any questions, recommendations, and discussion? Dr. Brinton?
Really appreciate Dr. Lula's presentation earlier. Thank you so much. And this proposal looks very appropriate to me. I would recommend adopting this proposal if the team feels like that's appropriate.
Yes, Monette?
Yeah, I did just want to point out a quick consideration with the proposal as it's written. I was almost wondering if maybe something closer to Vermont in terms of the dosage strength could be applied instead of specific formulations, just because it allows more flexibility between patients to, switch between dosage formulations. It's just a consideration.
I found because the oral 4 milligram granule package has a lower age indication versus the chewable 4 milligram. They have two different age indication on their prescribing informations. And then the 5 milligram is also, I think these four are the only formulations and doses available for Montelukast. And between both of the 4 milligram, they have two different age indicated for different formulations. So, Dr. Gonzalez?
Would patients in the 15 years old and up, if they're not able to swallow tablets, would they be able to submit a prior authorization to get a chewable? I think that's
Yes.
what kind of where our concern was.
Oh, gotcha. I see. Yeah. So if they are 15 years and up, they can use the chewable because the chewable is 6-year-old and up.
Okay, I see.
Yeah, we don't have the cap up the end. We only have cap up the lower age.
Okay, great. Yeah.
Dr. Kosinski? I think you are muted.
But I think it was that there's a quantity limit of only 30 per month, right? So if they do the chewable, then would they be able to get a prior auth for a 10 milligram? So that'd be 2 tablets, so 60 a month.
Yeah, so right now we don't have the quantity limit on our proposal, but if that's something that the board would like to recommend it, we can also consider putting a quantity limit with the exceptions of prior authorization. Yes, for exceeding quantity limit. Yep.
Yeah, I was just saying with like all the Medicaid providers do have a quantity limit. So I was just trying to make sure that there's a way for those 15 years and older to do a 10 milligrams of chewable.
Yes. Yes, there is a pathway to obtain prior authorizations and get exceeding quantity limit that way. Yep. Dr. Brinton and Dr. Smith.
So with knowing then that these are ages and up, does our pharmacy team also feel that this is appropriate, or do we need to change anything like to make the chewable available earlier? Or I will say personal experience, my kids were accidentally prescribed the granules and it was so much more expensive than the pills would have been for my teenagers. And I realize this is Medicaid, we don't have to worry about that as much, but anyway, just and I take care of patients that have G tubes, and so we're often crushing things, and granules sometimes clog the tubes. Anyway, just is this sufficient knowing that this is up, or would you guys on pharmacy side recommend that the granules or that the chewables also be available for a lower age group, given that they would not necessarily be chewed? I just don't want to limit that access. What does the pharmacy team think?
And Dr. Smith?
I want to hear the answer that the pharmacy from the pharmacy team.
So yes, there's only a pathway to access exception to policy, which is through the prior authorizations. So if the provider has a rationale for why the chewable would be appropriate for a children who's under 2 years or 6 years of age to grind it for the tube, they can always submit the prior authorizations and give us a rationale for considerations.
Okay, with that said, I'd like to make a motion to approve the age limit proposal as written.
Thank you, Dr. Smith. And Dr. Hoffman, you have a comment?
I do. Given that, I guess I just don't want to introduce additional hoops and hurdles for special populations like those with feeding tubes. Given that it's really only the oral 4 mg granules that have that lower age limit, what if we removed the formulation for the 3 below that and left the oral 4 mg granules for 12 months? And then the others, just the dosage. Just a thought, kind of hearkening back to the recommendation related to how Vermont does theirs for the older kids.
I'm sorry, would you?
So I would leave oral 4 mg granule package 12 months and older, and then just remove the formulation of chewable and tablet for the other recommendations.
Oh, so you would like to not having the age limit on the 4
No.
milligram, 5 milligram, and 10 milligram?
No, have the age limit, but not the formulation. So then it would just be 4 mg 2 years and old and up, 5 mg 6 years old and up, 10 mg 15 years old and up, without the formulation listed.
Oh, I see. So no chewable.
Exactly.
I see. The issues is those are the 4 milligram only available in either the granular package or the chewable. Those are the only 2 formulations is available. But yeah, I understand the recommendations. Would that be better?
I defer to those who are asking questions. It's just a suggestion to alleviate the need to have to go through a PA for an exception. They
Thank
can,
you.
yeah.
Thank you, Dr. Hoffman. Dr. Winston?
Yes, I was thinking the same thing for that situation where the dosage formulations need to be converted, but it's not a dose change. And then that gets into that quantity exception. So I was thinking along the same lines Dr. Hoffman was. We could also remove the the tablet word from the 10 milligram. And I think that achieves the same thing as far as dosage is concerned, and allows the clinicians more flexibility in the field. I had a question which we can maybe defer until after we vote on the proposal that has to do with any education efforts, given all the data we heard from Dr. Lulo. Thank you.
Yes, that was a great, and the pharmacy team also have a thought of publish a MIP, Medicaid information bulletin, informations about Montelukis and the risk associated with it as well, on our upcoming MIP in maybe a couple months. Yes, Dr. Lulo.
I did just want to point out that the oral granules for 12 months and older is indicated for patients with asthma, whereas patients as young as 6 months of age can take it for perennial allergic rhinitis.
Thank you. With that, do we have any more other comment, questions, or we have a motion? Dr. Brinton?
So then do we need, so before we can vote on Dr. Smith's motion, then should we change that a first line to be 6 months for allergic rhinitis and 12 months for asthma, just to clarify that, so it's not limited? What do you guys think? And Dr. Smith, are you okay with that adjustment?
the recommendation is to have the oral 4 milligram granules package limits from 6 months or and up. Yes, Dr. Smith.
I was just gonna say, I accept the amendment to the original motion.
Thank you. Do we have a second for the proposal as stated?
Second.
Thank you, Dr. Weinstein. All in favor?
I,
Aye.
Aye.
Thank you. Any opposed? Motion passed for having the A limits on the Montelukast as stated. The next item on the agenda is the prior authorization of Ivakit.
Good morning. My name is Sapira. I'm a Medicaid director for Utah Pharmacy. So for the prior authorization for Ivakit, and Noon, do you want to put it on do we have it to present it to the group, or do you want me to just kind of read through it?
I can present, Sapire.
In case they wanted to read through it. So it's a kinase inhibitors. It's indicated for gastrointestinal stromal tumor GIST, excuse me, and advanced systemic mastocytosis and indolent systemic mastocytosis. So when you look at the PA, with the studies that it's been done, this is not recommended for pediatrics with patients 18 and older. And also because of the complexity of this medication and the treatment, we wanted to either the patient be on the care of oncologist familiar with this medication, or a prescriber who is going to be consulting with this type of prescribers. And we wanted to make sure that under the gastrointestinal stromal tumor GIST, which with unresectable and also the platelet derivative factor receptor alpha exon 18 mutation, we wanted to make sure that we have that consideration. And based on the reference of the NCCN recommendation, we wanted to make sure that if there was any failure with the two medications that is indicated in the PA. So when you look at in the PA, under the advanced systemic mastocytosis, we do want to make sure that we have the coverage for specific patients with aggressive systemic mastocytosis, and also anything is associated with MCL and SMAHN, which we indicated systemic mastocytosis with hematological neoplasmic. So the format that we have, we wanted to make sure to capture all of those indications, and the provider, they need to submit their documentation with answering to any of these. So if they are in this prior authorization, if they are adult and also they're under the care of specific oncologists who are familiar with this medication, and if they are the population is specific as we indicated, if they have yes, then we submit that prior authorization to us. And the only thing that it's for all of these indications, we wanted to make sure that they have the higher platelet count of 50 billion per liter. Any question of that PA? And I think I covered majority of that. Dr. Smith?
Yeah, I guess I'm a little confused, and maybe it's because I wasn't at the last meeting, but are we changing an existing PA? Is this a brand new PA? And I guess has there been a presentation on this medication to the board?
That is a good question. Again, this is my second time to be involved with the DUR. So I am did we have a presentation on this in previous meetings?
Yes, sorry, I was muted. We haven't had a formal presentations on this medications. So this medication was previously included by using the rare disease PA because the populations on this medication is not as much, but we are moving away from using the rare disease PA for every orphanage drug, and these are one of them. And now it has its own prior authorization criteria. And these criteria are established based on prescribing informations and clinical study that was in the prescribing information. And also, this is a new format of our prior authorization that we are moving forward using the yes/no questions. So the provider can fill in what appropriate and applying to the patients. But short answer, we haven't had a formal review on this one, and this is the new PA.
Okay. I personally wouldn't feel comfortable voting on a PA without a bit more information, just from my standpoint.
Thank you, Dr. Smith. Dr. Hoffman?
Yeah, in particular with that transition, I would also be curious on utilization data below 18 years of age for off-label use. So I think I would like more information.
Thank you, Dr. Hoffman.
Thank you.
Dr. Winston?
This is just a verbiage question, and agree with the other comments. It might help to have at least a little bit of a summary for those of us that aren't routinely prescribing these medications. On 3A, we have at the end of that, it says recommended generic medications. Do we need the word generic there? I'm assuming most patients, the idea is a step therapy here, but if a patient had a formulation of one of those drugs that wasn't generic, we would still want to include it, if I'm understanding correctly.
Based on what I'm seeing in PAs and the research that we've done, we wanted to be true to what the recommendation is under NCC. And so that's why we brought a generic medication. I'm fine with removing that, but and one of our pharmacists, she worked on this one and she has more information. But based on what we looked into, it's a specific comes from the NCC and they're recommending the generic medications. But I'm fine with removing that.
Valerie, you have a comment?
Yeah, I've been through some NCCN guidelines recently, and I think they use the generic words for the drugs, but they don't really, it wasn't really clear to me that that is intentionally saying you have to use the generic, because a lot of the generic terms they're using are for drugs that are only available by brand. And I guess just one more point is that I think I could be wrong and it could have changed, but I thought that Utah Medicaid might have a brand over generic for sunitinib right now. Do you know?
Yes. We don't always refer brand over generic. It depends on the certain medication and situations. So it's applied to different medications, but I think the general idea is that they can use different manufacturers generic of these medications, but yes, we can remove the word generic from this PA.
And just to address that, yes, Sutent is a brand preferred over the generic sunitinib.
Thank you. I think that achieves the same purpose in terms of the flow of the PA. And in the event that either one of these medications might go back and forth between generic and brand, then it's covered and we don't have to change the language depending on the circumstance.
Thank you.
Do we have any other questions, comments on the PA? What I'm hearing is we don't have emotions for this PA. Would the board like more informations on the medications before making the decisions or making the motions? Okay. From now, I mean, we can bring it back with additional informations or a brief presentations on these. The issues is we have a lot of orphanage drugs that we are moving away from the rare disease PA. And we will have to bring them all to the board for having motions and recommendations. And we will try our best to give a reviews on those drugs when we presenting the PA. But that might be a lot of information, but we will try our best to do that moving forward when we bring the PA to the board. Dr. Hoffman?
And I think that's great. I guess I'm not looking at the rare disease PA. I apologize. I'm in a bit of transition in traveling, but how is age managed in the rare disease PA?
I'm so sorry. Can you repeat that question, Dr.
How
Hoffman?
is age managed in the rare disease PA for pediatric patients?
Oh, how is the age? Oh, yes. So the rare disease PA is more of a generic PA where we ask the provider to prescribe medications aligned with the prescribing informations. If there's any exceptions to, I mean, not exception, but if there's anything like the age limit is not what the prescribing information is, they have to give us compendia or literature peer review material showing that the age or any other indications that not in the prescribing information has to be proving effective and safe, just like in any literature review.
Thank you. I appreciate that. I recall that from several years ago when we did that to address this issue for pediatrics, where often research is not at the level where it is for adults. And so I guess, I mean, my concerns would be resolved on this one. I'm really stuck on the age limitation. If that language is included in each of these as we transition over to individual PAs, that would alleviate some of my concerns.
Oh, I see. Yeah. So we will still likely to be addressing by age based on the prescribing informations. And again, there is a pathway, or we call it off-label criteria, where the provider can submit the material to bypass that. Mm-hmm.
Yeah, thank you.
Mm-hmm. Okay, with that, I will maybe bring this back another time. Dr. Winston?
Yes, well, I was just wanting to respond to what you were saying about the volume and also for logistics expedience, to bring these forward with individual PAs. Maybe there's a kind of a modified presentation that could accompany it, that gives us a summary, but may not be, the kind of in-depth report that we get for some of the other things that we consider, so that we can accomplish what you need to in terms of transferring these over, but gives us a little bit more background, so we feel like we can make an informed decision. I would like to, submit this today, and I don't want to get us into a huge backlog with all the other work that needs to be done. So I was trying to think of a way to kind of split the difference. It could be just maybe even a one pager that says this is being moved over and any considerations, and you can bring the relevant, information that that we might need, just in a condensed way.
Yes, Dr. Wentz, thank you for the recommendations. I think from now on, these I will try to include these draft PA in your reminder email, so that you have some time to look over the criteria. Also, maybe like a RIF information, or at least the package insert. And a RIF introductions, that what happened to these PA before it was in the rare disease is moved to its own individual PA. And then there will be at least the prescribing informations to be attached in the email. So you be aware of the indications or anything that we make out the criteria for. And if we have time during the meeting, we will have like a brief presentations for it, really close to the package inserts as the minimal. All right, for the sake of time, let's move on to the next item. The next item on the agenda is the proposed criteria for IPKISA. Similar situations, this would, it was used, it was on our rare disease prior authorization, and now it has its own individual PA. The criteria is all of the following criteria must be met. Is the patient at least 5 years of age? Does the patient have a diagnosis of homozygote familial hypercholesterolemia? Is the patient currently treated with other background HOFH therapy and is unable to reach their LDL goal at the maximum tolerated dose of the background therapy? LDL goal, and then we ask for the LDL level while it's on the background therapy, and the detail of the background therapy and the detail of failure. And the next question is IPKISA being used as an adjunct to a maximal tolerated dose and intensity statin therapy, Zetia or PCSK9, unless contraindicated or serious adverse event for HOFH? And the re-auth criteria is, has the patient had clinical significant improvement as shown by the specific appropriate monitoring parameters and or improvement in symptoms, such as the LDL is now at goal, or the patient has at least 30% reductions of LDL from the baseline? Does the patient continue to receive concomitant lipid lowering therapy as the maximal tolerated dose, or have an intolerant or contraindication to other lipid lowering therapy? The initial term is up to 6 months, and the re-auth term is up to 1 year. And we also has a public comment. Would the board like the public comment before having the discussions? You can do that. Dr. Anderson, if you are here, you have 3 minutes in front of the board for the public comment.
Hi, everyone. My name is Scott Anderson. I work in medical affairs at Regeneron, and I have been working on IPKISA evinacumab for the last 4 years. After reviewing the criteria I see here, I don't have any need for extended comment, but I will stay on the line if there's any questions for the manufacturer. Thank you.
Thank you. Any questions, comments from the board about the criteria? Or similar to advocate, would you like me to maybe send maybe additional informations on this PA as well?
I think this one feels a little more straightforward than the last one, so I don't want to create unnecessary work, but I'm curious what others feel.
Dr. Smith?
I agree. We've at least talked about similar medications, but I would also like to see a summary before voting on the PA.
Anyone else? Any other comments, questions? Okay, so maybe we can make motions to bring it back for additional information.
So moved, Yoon.
Thank you. Okay, so motion to have it bring back or send having additional informations on these two drugs with the PA.
I second that motion.
Thank you, Dr. Siegfried. All in favor?
Aye.
Aye.
Thank you. Any opposed? Alrighty, motion passed. I will send additional informations for these medications. So we have the next meeting next month on June 13. The topic will be concurrent use of muscle relaxant and hypnotic agents used with opioid. With that, do I have a motion to adjourn?
I'll move to adjourn.
Thank you, Dr. Hoffman. Second, do I have a second?
Second.
Thank you. All in favor?
Aye.
All right. See everybody next month. Thank you very much.
Thank you.
Thank you.
Thank you.